focus on prediabetes. Now, this is what prediabetes is. So it sits right between what is normal and diabetes. But don't forget that why we are worried about this prediabetes is that last column there, and that's the complications. In fact, just on New Year's Day, on Twitter, I just put out a little teaser kind of thing, and I said to all people in the world on Twitter who are seeing this, what would be your 3 wishes if you had diabetes? What would be your 3 wishes? You know what? Most people said, you want to go off medication. That was the first choice. So I said, okay, it's not a bad thing to wish for. Of course, many said, we want a cure, and we want this, and we want that. And so I said, so yesterday I gave my response. I waited for a few days, and I said, okay, I don't have diabetes, but if I had diabetes, my wish would be that I should have a long and healthy life despite diabetes. That I shouldn't have any complications. I shouldn't go blind. I shouldn't have kidney failure. My feet which God gave me, I should have till I go back to God. Nobody should chop it off. And I shouldn't have a heart attack or a stroke and shouldn't be bedridden. That would be my first thing, that I should be like a normal person. That would be my first wish. All other things are secondary. If it gets cured, okay, fine. If I take medication, so be it. If I don't need medication, that's also a blessing. Okay? So it's that last one which you're really worried about. And all the treatment, all that we are doing is to ensure that people don't get into that last stage. In prediabetes itself, straight away as you can see, it is not one condition. There are 2 conditions under prediabetes. One is where the fasting glucose is elevated, but the after food one or the post glucose one is normal, and that's called impaired fasting glucose. The other one is the opposite, where the fasting is normal and the 2-hour is elevated, and that's called impaired glucose tolerance or IGT. Only after glucose load you will see that. You can also have both. You can have IFG and IGT. That's what is shown here. Now here straight away confusion arises because for IGT there is no problem. Everyone agrees. You give a glucose load, it's incidentally 75 grams now, Dr. Shikran, is the international standard for the GTT. So you take a fasting blood and then you give 75 grams of glucose, and at the end of 2 hours, you draw a sample, and if it's between 140 and 199, then it is impaired glucose tolerance. Now that definition everybody accepts. That's the kind of gold standard for pre-diabetes, IGT. But then the problem comes when people say, don't need a GTT and so on. That gets more confusing. And that's what the American Diabetes Association said. We don't have time to wait for 2 hours to do an OGTT, so let's try to do everything with fasting. Now the fasting, according to the WHO, it becomes abnormal only at 110. It's very important for you to understand this. And this is what the International Diabetes Federation has accepted. This is what the RSSDI, the Endocrine Society of India, the Association of Physicians of India, everybody has accepted 110. There's only one group which has not accepted it, that's the American Diabetes Association. And they have lowered it to 100. So they say from 100 onwards, it is pre-diabetes. So the problem when you lower it to 100 is, if I now randomly come and test all of you and check your fasting blood, 30% of you will have 101, 102, 103, and you'll probably never progress to diabetes. So that's an overkill. You're actually over-diagnosing. And what happens is, people even start metformin and all at that stage for them. You don't even have anything abnormality. They even then go and start treatment, medication, 2 drugs and all that are given when you don't even have a problem. So for this audience, I would be happy if you took 110 to 125 as being pre-diabetes, which is the impaired fasting glucose or IFG. And going very slow here, because I want this IFG and IGT to be ingrained in you. So the rest of my talk is on that. So if you didn't get that right, then you're going to get confused with that. Now another confusion comes with the HbA1c. Now HbA1c below 5.6 is normal. Now the ADA, because it doesn't want this OGTT and doesn't want this IGT, they have accepted a HbA1c criteria. So 5.7 to 6.4 is pre-diabetes according to ADA. The WHO didn't accept that. They said, too many people have 5.7, 5.8. You can't call that as pre-diabetes and label because it's not on metformin also. Normal is 5.7, metformin is started for people. Okay, this is a normal rate. Another fact I want to tell you, which we have shown in our ICMR and DAB study, which I'm going to refer to shortly, is that with age, glucose levels go up. Your HbA1c goes up. So you cannot take a 30-year-old and a 70-year-old and give the same values to them, because at 70, most people will have HbA1c of 6, which is normal for them. 6.2 is normal for them. They are not pre-diabetic at all. So you cannot take the same pre-diabetic value for a 25-year-old person and a 75-year-old person. Let's treat that separately. 25, 30, yes, it is abnormal. It should not have been 6 or even 5.8. Okay? So that is the figure, and if you want to take pictures, that also you can do, because this is a very fundamental one. And never use HbA1c alone for diagnosis of diabetes. That's another point I want to tell you. Either for pre-diabetes or even for diabetes. Because HbA1c standardization is very difficult. We haven't achieved it in India. Glucose, we have reasonably achieved accuracy. If you do it in a lab in Mumbai and lab in Chennai or in Jodhpur, you will get the same result. A1C, one lab will tell you 6.5, another lab will tell you 8.7. Completely different. How are you going to, so in Mumbai you have diabetes, in Jodhpur you are not diabetes. So, I mean, it doesn't work. So until we get our A1C completely standard, use A1C for follow-up, for treatment, to see whether it's coming down. Once you have a value, don't use it for diagnosis. Use always glucose for diagnosis. Okay, so this is the ICMR and DAB study. This, the first author of the study is my daughter, Anjana. It's her idea. She wanted to do the study of the whole country, to look at the prevalence of diabetes in the whole country. Now, India has a population of 1.44 billion people. It has so many languages, so many cultures, so many states in India. And to go and do a study of the whole country is nothing short of madness, in my opinion. But she wanted to do it. And she persisted with it. And believe me, the study took 15 years to complete. 15 years. And for 15 years, we were doing the same study in different states. That's how long it takes if you want to do a complete study of the whole country. In fact, it is so challenging to do the study that after this paper was published in the Lancet, the editor said, can you write one more paper on the challenges of doing India? That's a paper by itself. And that got just published last week. You know, that's how complicated it is. But to cut a long story short, on June 7th, when this paper was published, it created a sensation because India's numbers went up. Okay? Now that's a new number for India for diabetes, 101 million people. Now that's 4 times Australia. Just the number of people with diabetes in India is 4 times Australia. It's more than the entire population of UK. It's more than the entire population of Germany. That's the number of people we have with diabetes. And if you thought diabetes wasn't bad enough, next to it is pre-diabetes. 136 million people. Okay? There are not too many countries in the world. If you combine those two, diabetes and pre-diabetes, it's 237 million. How many countries in the world do you know which have a population of 237 million people? Only 2 or 3 in the whole world. So that's the number of people that we have. Now to me, that 136 million, although it sounds very alarming, is actually a window of opportunity. That's why we are all here. Because unless we do something collectively, addressing that 136 million people, they are going to convert to diabetes. And again, I'll show you that they convert very fast in India. So that 101 million can become 120 million, 150 million, 200 million, and then all of them may also have a risk of developing complications of diabetes. That is something which our health system cannot take. And therefore, we have to focus on pre-diabetes. So that's just to show you pictorially how India would look if you put the prevalence. Now, on top is urban, and below is rural. Now, red means 10% prevalence and above in various states of India. You can see almost the whole country is red. If you take urban, and urban is not Mumbai and Hyderabad and Bangalore, you have got small cities. Your Nagpur is included, your Pune is included, even smaller towns are included when you say urban. Anything which is not a village is urban. That's already 10%. And the whole country, except one UP, okay, and luckily UP has not reached, say, UP itself has a population of 200 million people. So even if 1% goes up in UP, that's a lot of people with diabetes. And they're getting there, don't worry. Next time we do some study, UP will also be there. But look at rural, there's still hope that in rural India, we still don't have too much of diabetes. But if we now switch to pre-diabetes, those are the pre-diabetes numbers, even in rural, you're finding a lot of red. So what's the message? What's the message? Tell me. If rural is not that much diabetes, but there's a lot of pre-diabetes, what does it tell you? In the next 5 to 10 years, in rural areas also diabetes is going to increase because pre-diabetes just converts into diabetes very quickly. And therefore, all those reds that you're going to see as pre-diabetes will also become red as far as diabetes is concerned. Then those numbers may not even stop at 200, 250 million, if we go even more as far as diabetes is concerned. And if 1/5 of them, is a very conservative number, develop, let's say, kidney disease, where are we going to go with dialysis machines and transplants and get kidneys? And even now, with 100 million people, let's say 20 million ultimately need a kidney transplant. You know how many kidney transplants are done in the whole country in a year? 10,000. We're talking about 20 million, almost from Australia, with only kidney problems in India. So it's huge. And therefore, this is not something which it's not rhetoric. It's not something I'm just telling you to, let's all give him a clap and then we go. We have got work to do, ladies and gentlemen. We really have got a lot of work to do in India. Okay. This is just to show you that at what age group you have pre-diabetes, urban, rural. Of course, it goes up with age, because diabetes goes up much more steeply with age. Now, this paper was published quite recently, and this is the best paper you can ever get on pre-diabetes in the world. It's published about 2 months ago, I think, 3 months ago, in Diabetes Care. It's on global prevalence of pre-diabetes. For the first time, a paper on the whole world's pre-diabetes situation has been published by Rooney and colleagues. Now, when this paper was published, India was not quoted. And something very strange I saw in this paper. What I found was that if you look at impaired glucose tolerance, okay, this is by regions of the world, North America, South America, Southeast Asia has the lowest prevalence of impaired glucose tolerance, but it has the highest prevalence of impaired fasting glucose, IFG, exact opposite. So we seem to have higher fasting levels, which is why I said, for heaven's sake, don't make 100 as your normal. We have a tendency to have a higher fasting. So 110 is a safe cut point for us. Even taking 110 as a cut point, our IFG rates are very high. So we have a lot of impaired fasting glucose, less of IGT. And this is pointed out there, but they said Southeast Asia, which we actually South Asia. So I immediately wrote to Diabetes Care and said, hey, we have got INDIAB data from India. And we are confirming what you said, that in Southeast Asia, Rooney et al. Said that in India we're having the same thing. In INDIAB, we're showing that IFG is much higher than IGT. Now this is again not a theoretical exercise. It has a lot of implications for you, as I'll show you in a minute. Because IFG responds very differently to treatment, to prevention, than IGT. IGT is much easier to prevent from going to diabetes. IFG is much bigger challenge, and unfortunately we've got IFG more in our country. So that's what I hope. So when we talk about from pre-diabetes, preventing somebody from going to the stage of diabetes, that's what's called as primary prevention of diabetes. Once you have diabetes, preventing its complications is called secondary prevention. If you already have complications, you're still trying to do something, that's called tertiary prevention. How can you prevent something? Well, one eye is gone, try to save the other eye. One foot is gone, try to save the other leg, at least. So that's tertiary prevention. I know it's very late in the day, but as doctors, we can't say, oh, we should have come in primary prevention stage. I'm a primary prevention doctor. I don't do tertiary prevention. The guys come with a gangrene, you have to look up as gangrene, isn't it? Or some laser treatment needs to be done, or intravitreal injection has to be done. We can't leave them off as doctors, we have to treat them. But we wish they didn't get there. Wish we had come earlier, we treated their diabetes well, and prevented them from going to complications. Or still earlier, as all of you, if we can attack the problem of pre-diabetes, we have prevented diabetes itself. The stage before that, normal glucose tolerance, primordial prevention. You don't even have to go to the stage of pre-diabetes. Every one of you who is not exercising, who is eating unhealthy diet, you are on the way to develop pre-diabetes. And there you can start primordial prevention in the community. If you all decide that from tomorrow morning you're all going for a job and you're going to be healthy, you're doing primordial prevention. You don't have to wait for pre-diabetes to come because these numbers in India are going up. Okay, let me just ask you, how many of you in this room, it's a random, I just come to a random lecture, I'm just meeting random people. So, how many of you in this room have at least one relative with diabetes? I'm not asking about you. You can also raise if you have, but look around. Just look around. Very few hands are not gone up. So primordial prevention you should all be doing. You all got relatives with diabetes. I'm not talking to somebody else, I'm talking to you. You are also involved in this. Okay. Now let's look at how does the conversion occur. Now look at conversion from normal or pre-diabetes to diabetes. You need longitudinal studies. India, big though it was a cross-sectional study. At one time, what is Kerala, what is Maharashtra, what is Tamil Nadu, that we have managed to do within that. But if you want to know how many people are converting from pre-diabetes to diabetes or from normal glucose tolerance to pre-diabetes or diabetes, you need a longitudinal study, which means that the same cohort you have to follow again and again and again after 5 years or 10 years to see how many converted. Then only you will get what is called as incidence data. Otherwise, what you get is prevalence data. Okay? So we managed to follow up another cohort we had in Chennai, called as the Chennai Urban Rural Epidemiology Study, 10-year follow-up of that. So what we did was, initially studied the Chennai cohort in 2001, and then about 10 years later, went back and followed up those who had normal glucose tolerance. Now, do they progress or not? We wanted to see. And the results are shown here. We had 1,000 people who we had done OGTTs, fasting was normal, 2 hours normal, no pre-diabetes, no diabetes, by any criteria, okay? 10 years later, when we went back and did the same GTTs on them, what we found was some had developed IGT. The I before it means isolated, they have only IGT. Some had only IIT, some had both. And we put all together IFG or IGT from those who had normal, now they have developed some form of pre-diabetes. It is 29 per 1,000 person years of follow-up. What is person years of follow-up? If you follow 100 people for 10 years, it becomes 1,000 person years of follow-up. During that time, how many have developed? So it's 29 per 1,000 years of follow-up, which is very high. From NGT to pre-diabetes, believe me, this is a very high rate. But look at the one below. By that time, in the 10 years, 22 per 1,000 person years of follow-up have developed diabetes itself. They have zoomed through the stage of pre-diabetes and jumped from NGT through pre-diabetes into diabetes. This is only a 10-year period. This is not a hospital-based study. This is a whole representative sample of Chennai city. And I have no reason to believe that Mumbai will be any better. Okay? It will be the same all over India. So that's how fast people are developing diabetes. We compared this with 5 other international studies which are available. The Danish study, the Nauru study, the American Indian study, our study, and the PIMA Indians. And for a moment we were happy. We said, for the first time we have come in second place. We are not the worst in the world. Okay. There is one ahead of us, it's the PIMA Indians. They had a faster rate of progression, 87 per 1,000%. We are only 78, 79. So we are very happy. Then we realized the fallacy. Their BMI is 33. Our BMI is 25. With a BMI 25, we have reached there. If you do a simple statistical calculation, make our BMI 31, we are far ahead of them. Or you make their BMI 25, they are far below us. So we are number 1 in the world with that also. Okay? Unfortunately, in the conversion rate also, we are the fastest. This is the first time that we showed that Indians have such a fast conversion rate. This was followed immediately by a publication from the UK where they looked at South Asians. How do they progress from normal glucose tolerance through IGT to diabetes? The red line is South Asians, mostly Indians, Pakistanis, Bangladeshis also included in the UK. And the blue is the white Caucasian population. And you can see much faster, even in the UK, the South Asians are developing both pre-diabetes and diabetes. So what I said about those numbers converting is actually shown in another independent population as well. Now, why is it progressing so fast? So that was the next question. So for that, what we did was, we studied the insulin secretion in our population. This is again a Chennai-based study, 26,000 people where we studied. We did OGTTs on them. We did fasting, 30-minute sample, and a 120-minute sample. And the fasting and the 30-minute, you have the glucose and the insulin. You can calculate what's called as the disposition index, insulin disposition index, or the DIO. And Ranjini, one of the authors, is in the study. This is part of our D-clip study which Ranjini did. You can see that by the time you develop impaired fasting glucose and IGT, already your insulin level is coming down. And if you have both IGT and IFG, it's dropped drastically, your insulin secretion, you still not develop diabetes. By the time you develop diabetes, about 80% of your beta cell function is gone. So what we are showing in those stages, normal, pre-diabetes, diabetes, we say, I just developed diabetes last week. Unfortunately, 80% of your beta cell function is gone by the time you develop. The good news, however, is that by aggressive treatment, by weight loss, you can actually improve your insulin secretion. And that's what all of you do. You measure your insulin, then you find it's coming down, and insulin resistance going away. That's what happens. So you can activate it to some extent. There's a point of no return. At a certain point, the pancreas will fail. The cells will die. And then it's a point of no return. That's when you actually need insulin treatment and so on. So the point about this is that what we think as pre-diabetes is already an evolving stage where the beta cells have already started failing. And what you see in red is insulin resistance. Insulin resistance going up with the HOMA-IR. So both are happening. On one side, insulin resistance is increasing, the other side, insulin secretion is going, and the stage is set for you to develop diabetes. Now, just a point to tell you that pre-diabetes is not just about developing diabetes. It's also a harbinger of cardiovascular disease. So the clock starts ticking for cardiovascular disease, for myocardial infarction. We heard about the school student who developed heart attack this morning. Somebody is mentioning that. It's all because even in the stage of pre-diabetes, you are as prone to get a heart attack as if you had diabetes itself, because so many other things go wrong. Dyslipidemia sets in, your blood pressure starts going up, chronic inflammation sets in, insulin resistance is there. All this makes you more prone to heart disease. And by treating pre-diabetes and normalizing it, you are actually reducing the risk of heart attacks as well. And this is another data from our own study showing that at the stage of IGT itself, the risk of heart disease goes up. These are actually measured using ECG and doing Minnesota coding. And if you look at the carotid intimal thickness. All you have to do is put a probe there and measure the carotid intima thickness. It's a very nice index of atherosclerosis. You will see that from normal to pre-diabetes to diabetes, it's going up. If you just focus on the pre-diabetes part, you can see how different they are from the normals. Already they started getting disease. It may be reversible, but again only up to a certain point. Okay. Now let me go to the prevention trials. All the prevention trials, and my father actually, Dr. Shukran will be interested to know, 1950s he was talking about prevention. 1960s he was talking about prevention. 1980s when he talked about prevention as the presidential address of the Association of Physicians of India, here in Maharashtra, when he gave a talk, he said, oh, diabetes is not preventable. It's a hereditary disease. How can you prevent it? It was only in 1996 that the DPP, the 3 months after he died, unfortunately, that the proof of prevention actually came. Something which he's been talking about for 30, 40 years, saying prevention, prevention, prevention. The actual proof came after he died, 1996. That was the first study to show that diabetes can be prevented. They took people with pre-diabetes, put them on exercise, lifestyle, weight reduction, and they showed no progression to diabetes. Quickly, the Finnish study came, Chinese study came, Indian diabetes prevention study, which my brother-in-law Dr. Ramchandran did in Chennai, was also published. So there was no doubt that diabetes could be prevented. Unfortunately, all those studies only included people with IgT. They completely forgot about IgT. Only IgT was included. That's where Ranjini came to the picture. She and Mary Beth from Emory University, they worked together, and the now famous DCLIP study was done, where for the first time in the world, we included IgG also, IgT also, IgT plus IgG also. This was followed by the Kerala study and 2 other studies which done later, but ours was the first. And so this is to show that in IgT, up to 30%, 40% you can prevent, and in Western world, even up to 60%, 58% you can prevent diabetes. But what about IgG? Now this is the DCLIP study. In DCLIP, what we found was that even after 16 lessons were given to people were brought in, they were trained how to reduce their carbohydrate, fitness programs were conducted, then they become leaders. It's a community-based program led by Ranjini. And at the end of it, what we found was, if you had IgT, 31% of prevention, that means 31% of people did not develop diabetes. If you had IfG plus IgT, 36% could be prevented. But look at isolated IfG, only 12%. Now these are people who had diet, exercise, weight reduction, and if this didn't work, metformin was also added. Even after that, only 12%, the rest developed diabetes. Why we are putting this program? We didn't separate them out by IgG and IgT. We put everyone in the same group. One group is not responding. So this is the first time in the world. That's why I wrote in that diabetes care paper. We are not simply saying South Asia and Southeast Asia is different. IgG responds differently, and that's what we have. We have a lot of it. And so we said, yes, you can prevent it in those with IgT, but with IfG, we don't know what to do. We have to now find new studies. Okay. Right. This is the Kerala paper. This is the Kerala paper which followed, showed the same thing. Kerala Diabetes Prevention Program. IgT works, IfG doesn't work. 2 more studies were published. One from Japan and one from the UK. And then we wrote this paper saying, very recently, about a month ago, we wrote this paper in Diabetes Care and said, you should have a different approach now. Don't say everybody with a pre-diabetes will respond. Say which type of pre-diabetes. This became a big hit when we published this, and I think it was December 2023, as late as that. And there it is. So you can see those with IgT are responding much better. IfG, it's not crossing the midline at all. That means no response. So then we put this together all the 4 studies published and said in IGT, the hazards ratio 0.65 means 35% reduction. Hazards reduction 0.51 means if you have combined 49% reduction. Look at IGT alone, it's 0.97, 3% reduction. 3. We had 12 in our study, we put all the other studies together, again 3%. We're not able to prevent IFG. And that's the one we have more. And that's the one which is progressing very fast. And that's why it's probably progressing very fast in our population. This had never been realized until 4 weeks ago, believe it or not. And so, this paper was selected, there's an article, there's a commentary written on this by Bill Herman from University of Michigan, which says that now a new approach to pre-diabetes, we all have to now focus on a new approach, and this paper was actually selected as the best paper of this diabetes care issue, saying that we are now completely, we have to look at pre-diabetes in a different lens. And you're lucky that you're the first time in any conference that I'm presenting this. Why is it different? I won't go into it, but there is solid pathophysiological evidences. In IFG, the pathophysiology is mostly in the liver. The insulin resistance is in the liver. With IGT, it is in the muscle and the adipose tissue. The glucose is not getting utilized. Here, the liver is at fault. And therefore, maybe one of the drugs which works on the liver will probably work better. Maybe a small dose of SGLT2 or something. When diet and exercise is not working, what do? Something you have to do. We haven't solved that, but this is coming up now. I'm just going to finish. Forget about people who come to you one-to-one. Most of us practice with one person coming, okay, I got a little higher sugar value and HbA1c, told me pre-diabetic, what do I do? That you can tell them individually, you do this, you do yoga, you do exercise, you do this, you do that. What do you do on a population level basis? When you have a whole country, 1.44 billion people all racing towards diabetes and pre-diabetes, it's not going to work. The one-to-one is not going to work. You do something at a population level. One thing that we did was we knew is that we're eating too much of carbs. As a nation, we're a carb nation eating too much of carbs. So we went back to India and said, can we use a mathematical model? Now we cannot put somebody on a randomized clinical trial for the next 20 years. Ask them to reduce carbohydrates, 1.4 billion people, reduce their carbohydrates. It's not going to work. Who's going to do such a trial? So we had to use mathematical modeling. So we brought in a mathematician, Dr. Shesha Srinivas, and said, here's our data. Here are normal in-diet people, here are pre-diabetes, here is diabetes. This is what they're eating. Now can you work out some mathematical modeling? We thought people may not be interested in that. Turned out to be a great paper because the results are very simple. What it said was, from the present carbohydrate, if you are able to cut 10% of that carbohydrate and replace it with protein, many people asked me when we came to the meeting, can we do some protein? Do you believe in protein? I absolutely believe in protein because this is India's answer. If you can increase 10% protein intake across all of your diets, all of you included, okay, and cut the carbohydrate on your plate, I believe we can prevent pre-diabetes and we can prevent diabetes. It's as simple as that. Of course, the fat can remain where we are today, but healthy fats have to be. When you increase the protein, if it comes from vegetable proteins, it's better because you get fiber also along with that. So your fiber also goes up. Again, something which will help your diabetes. Does lifestyle always work? Well, it usually works. It works in IGT, but need not always work. And we have been part of a very large group on precision diabetes. Dr. Bodhini, who works with me, and myself are part of representing India on this actually. In fact, 3 weeks from now in Vancouver, we have the next precision diabetes meeting, and I have to go because I'm representing India. So we wrote a series of 18 papers we wrote, and all the 18 papers were published in October, first week, on the same day, same time, 18 papers were published. All in Nature, Nature Communications and Nature Medicine. And here what we did was for each aspect of type 1, type 2, everything we had different publications. On type 1, type 2, diagnosis, prevention, treatment. We were actually in the prevention group. in that particular group we wrote. And our paper was with Bodhini as the first author, and myself as joint last author. We again published this in Nature Communications. So what we try to say is it a particular group of people who respond to prevention, or does everyone respond to prevention? The only point which actually came out was that IFG doesn't respond well. Otherwise, we have IGT, everybody seems to respond. Men respond, women respond, everybody responds. It's just our effort which has to go in. That is the good news. We couldn't find only this group will respond. That we could not find, which is good news actually. But problem is, once you start advising, you all know as dietitians and nutritionists, you tell people to follow diet and for how long? Question will come. It's lifelong, unfortunately. Okay? And that's what people don't do. They drop off. So then it comes up, should you use drugs? And I'll show you one example and end with that. Metformin is recommended today for pre-diabetes. The Drug Control of India has approved it, if needed. You do not use it anywhere, but if needed, it's an approved drug and you can use it. It's approved by all the associations as well. Now, I'm going to go into that. The RSSDI, WHO, everybody has drugs. Okay. So when we use drugs, and this particular slide, if you remember, here are two people with pre-diabetes, okay? One is a 42-year-old person. His father had diabetes, exercise is irregular, waist is 86 centimeters. The Indian diabetes score is not yet above 60, which is the high risk one. Fasting glucose is 99. 2-hour value is 149. I told you above 140 is IGT. Okay? So it's just 9 milligrams more. Why would you go and use metformin on this person? Ridiculous. Just little diet, stop sugar, starts exercising, this person will become normal. Look at the other person, 55 years old, both parents are diabetic, sedentary of course, but waist is high, the risk score is 100%, fasting is also high, 2 hours is 195, just 5 milligrams away from 200, which is diabetes. So technically he is pre-diabetes, clinically he is actually diabetic, okay? And this person, just giving lifestyle may or may not be sufficient. It may not be sufficient. So don't hesitate to use a drug if it is needed. Otherwise they'll develop diabetes and then you will give more drugs and then they'll develop complications, and the earlier you bring it back to normal is good. So using a drug is not a sin in those who need it, but you should know where to use it. You cannot use it in everyone. Okay? So by treating pre-diabetes, which is what we're going to do for the next 2 days, today and today, increasing physical activity, healthy diet, weight reduction, not only will prevent diabetes, but will prevent cardiovascular disease as well. And therefore, my take-home message, ladies and gentlemen, is that diabetes can be prevented if intensive lifestyle modification is done. As I showed you, IGT responds better than IFG. With IFG, we really don't know what to do. We're now forming an international group to sit down together and see what to do for IFG. Metformin can be used if you find that the risk is too high, or if they're not responding and you think they're too near the diabetes part. The 5 milligram doesn't make too much of a difference, an artificial cut point anyway. So drugs can be used, but that should be the last resort. Because in any case, EPP, IDPP, and all the studies show that metformin, that lifestyle is far superior to metformin. There's no doubt about it. Lifestyle really trumps. And with that, I'd like to thank you all for your patient hearing. And as I said, that the sooner people find out that they have pre-diabetes, take action, the better the chances of preventing diabetes. So the time to do it is now. Thank you.